Hello, welcome to the concept of elimination. In this particular module, we are studying UTI and BPH. And this is a shorter concept than some of the other concepts that we are looking at in Adult Health Med Surg 1. When we look at the concept of elimination, we think about some types of abnormal process within either the GU system, the urinary system, or the GI system, the intestinal system. And so in this particular course, we are looking at the GU system, which involves BPH and UTI. In future semesters, you all will begin to explore elimination issues within the GI system. So let's begin looking at BPH. So BPH is referred to as either benign prostatic hypertrophy or benign prostatic hyperplasia, and oftentimes they're used interchangeably. But looking at benign prostatic hypertrophy, this is where there's an increase in the prostate gland and it causes disruption of urine outflow. It is usually non-cancerous, related more so to the increased size of the prostate gland. Now, hyperplasia, the same thing happens. The patient they end up with a increased size of the prostate gland, but it's due to an increase in cell growth by multiplying. And so it's usually non-cancerous as well. There is a relationship when there's a decrease in testosterone as men age, and that would be coupled with an excess of testosterone, and higher portions of estrogen, which may account for the increase in cell growth. So just a little pathophysiology there. Can it ever be cancerous? Yes, it can, but usually not. Cancer of the prostate is a slowing malignant growth of the prostate gland that can spread to various parts of the body. There are 3 treatment approaches, and it's usually either just monitoring the patient, active surveillance, to see if the symptoms are getting worse or becoming more severe. They can also use medications and also surgery. So it really just depends on the severity of the BPH, and it also depends on the patient's wishes and also the provider. So looking at the risk factors, you can see that as males get older, they have a higher risk of developing BPH. And so it is very rare before the age of 40 that a male will have symptoms of BPH. And so as they get a little bit older, those symptoms, there's a higher risk of having those symptoms. So you can see as the male population reaches their 60s, we have probably more than 50% have symptoms. And then males in their 70s and 80s, it's a huge percentage jump, and that's about 90%. So who's at higher risk? African American, Hispanic men generally have symptoms earlier than the Caucasian population, and then Asian men develop symptoms later than Caucasians. So there is a little relationship to the ethnicity as well. So looking at the clinical manifestations, if you think about what's going on in the process of BPH, this makes sense. And so the patients will develop, urinary retention, bladder distension because they can't urinate. The urine is basically backing up into the bladder. Increased time to void, they're straining to void. They may have a weak urinary stream, incomplete bladder emptying, post-void dribbling, urgency, frequency. They may become incontinent, having nocturia, dysuria, bladder pain. And so diagnostic test, basically, you and I wouldn't be doing this as a nurse, but we need to be familiar with the tests that are performed on these patients. One of the more common diagnostic tests is digital rectal exam, DRE. And this is when the provider palpates the prostate to determine the size and consistency of the prostate. So you can see here where this is a provider doing a DRE. Okay. So urine flow rate test, this is usually performed to to give them an indication of the severity of the flow of urine. So the normal is 14 mLs per second. And so if this test comes back less than 10 mLs per second, there is an indication of obstruction. The PSA test, this is a blood test, prostate specific antigen. And so basically what they're looking for is to see if this number is elevated. If it's greater than 4.0, it is considered to be elevated. And at this point, they do become concerned, is it cancerous? Does the patient have cancer of the prostate? And so a biopsy will be performed at that time if that test comes back elevated, just to rule out cancer. And then post-void residual urine test. This is basically almost similar to what we do when we are doing bladder scans. So basically what they're looking to see is how much urine is the patient retaining once they void. So that's the post-void residual urine test. And then pressure flow study, this is just to see how fast or how slow is the urine flowing. Urinalysis, we're pretty much familiar with that. They just do a urine specimen. Urine cultures, they're checking to see, does this patient have anything as far as an infection or bacteria? So that's going to tell them what type of bacteria the patient has and how to treat it with what antibiotic, if they do have bacteria. And then cystoscopy is basically taking a scope. They're looking, in the GU system, and this just gives them a little bit more information about what's going on inside, things that we can't see from the outside. So nursing assessment, if you have a patient who has BPH, and remember I said the older the patients get, there's a huge percentage of our patients who do have BPH, our male patients, of course, who do have BPH, and if they haven't been quite diagnosed, they have symptoms of BPH. So as the nurse, a part of your assessment, you're assessing the severity of those symptoms. And so if you were to be documenting in your hospital electronic system or your EMR, you will find that if you click on like if the patient's having symptoms of prostate enlargement, there's a list of questions that you, the nurse, will have to answer. So there's questions that are related to urinary elimination pattern. There's questions related to clinical manifestations. And then also, you're always thinking, what risk factors does this patient have? And that's for any disease process. And so when you answer those questions in the EHR system, it's going to calculate up a score for you. And so that score can be anywhere from 0 to 35. Anytime it's 20 to 35, it indicates severe symptoms of urinary tract elimination. Or emptying. So that, would definitely be in a elevated number. So medical management, I want you to be familiar with 2 different classifications for this particular disorder. Make sure that you are aware of the reductase inhibitors such as finasteride, dutasteride, and then adrenergic receptor blockers such as tamsulosin. And so these medications, going back over to the reductase inhibitors, these medications here help to reduce the size of the prostate. And so a huge side effect of those are impotence, decreased libido, and decreased ejaculate volume. And so it's not always comfortable to talk to the patients about things like that, but we want to make sure that the patients are aware, especially if this is a newly prescribed medication. We want them to know that these are the risk factors. Now, hopefully the provider has told them this before they prescribe the medication, but it doesn't always happen. So we're usually that person that takes on that role. And that's a big part of our responsibility as a nurse to do patient education. So when we look at the adrenergic receptor blockers such as tamsulosin, these medications here help to relax the smooth muscles, and it's going to relax the bladder of the neck. It's going to help relieve the obstruction, and the patient hopefully can get urine through. The side effects of that, though, are orthostatic hypotension, and if they take an antihypertensive already, well, this may actually worsen the BP symptoms, so it may drop their BP even more. Now, remember, this medication acts on the smooth muscle, so there's not there's smooth muscles in more than one place in the body. And so it doesn't really dedicate itself just to the neck of the bladder. It can go into other places too. And if the patient, if, as I said, if they're on another medication that treats their blood pressure, they could really be having some effects of this receptor blocker because of the action that it has on the smooth muscle. So, it can act on the heart, it can act on the GI system, and so on. Okay, so let's talk about medical management surgery. There's a couple of different things that they may choose to do. Balloon urethroplasty and intraurethral stents. Those are less invasive than the open surgery is. But basically what they do is they take a catheter, a long catheter, they go up into the urethra, almost like a cardiac cath, which we will talk about in the next module. But the urethroplasty basically is a catheter that goes up, it goes to the urethra, it has a balloon on the end of it, and so they're pushing back that excess prostate tissue. And it depends, again, depending on the severity, they may need to put stents in. And stents are like these wired looking devices that they would place in the urethra via the catheter used to do the urethroplasty, and they push the stents in, and they deflate the balloon, take the catheter out, but the stents stay in place, and it's going to help keep the urethra open and the urine flowing. Now, if they choose to do surgery, there's laser surgery, which some of your younger urologists may be performing. And so basically what they're doing is going in and they're vaporizing the prostate tissue that's obstructing. And they can also choose to do an open surgery. So this just really means they're doing an abdominal incision. And there's a couple of different surgeries. TURP, which is a transurethral resection of the prostate. This is the surgery that is most often done. They take a resectoscope, and they use it to remove the obstructing tissue in several segments. So the segments are flushed into the bladder with an irrigation solution. So these patients will end up most often in the ICU setting post-op, and they usually have a 3-way catheter in place for urine drainage, and also a bag that's going to flush or irrigate the bladder, because this particular surgery is so messy, and patients do have a risk of bleeding or having a lot of bleeding just due to the removal of segments and tissue and so on. So that's the TURP. And then there's a transurethral needle ablation, or TUNA, and basically this one is used they use a low level frequency system, and they use twin needles to burn away a area or a region of the enlarged prostate. They also shield and protect the urinary tract during this procedure. There's also a TUIP, transurethral incision of the prostate. And this is where they take and they make small incisions in the prostate. The gland is split to reduce pressure, and this is most appropriate for men with smaller prostates. So they just basically split the gland and it's going to reduce the pressure. Complications do include, and this is for all of the surgeries, urinary tract infection, hemorrhage, especially for TURP, and clot retention, and also inability to void. So priority interventions do include administering antibiotics post-op, pre and post-op actually, preventative teaching. So if, once the patient is diagnosed, and if there's any teaching that needs to be taught as preventative teaching, as far as let's just use preventing your patients from getting a UTI. That would be a part of the preventative teaching, because these patients do have a high risk of developing UTI, for example. Insert urinary catheters, especially pre-op, And most often the urologist will need to insert the Foley catheter. And the reason why is because this patient most likely has a lot of constriction going on there, and you don't want to cause trauma to the urethra. So, sometimes they'll put it in order for us to put it in. And then if you can't get it, you've tried once, you've tried twice, I would not try anymore. I would contact the provider, the urologist, to put that tube in. And so they'll be happy to do that. They don't want to cause any issues for the patient, and nor do you. So you want to minimize manipulation once that tube is in place. You may need to give the patient pain relief, of course. So pain medication. Observe for urinary output. We're monitoring to make sure that they have adequate output. You're monitoring the vital signs. Monitor the labs. And after removal, cath care for sure. Also, too, once the catheter is removed, you want to make sure that you check for hematuria, monitor for burning, monitor for signs of stricture, straining of the urinary system, or like a weak urinary stream. Ambulate first post-op day is usually one of the orders that you'll find. And I think that's it. Okay. Okay, so patient education does include stop drinking fluids a couple of hours before bedtime, because remember, they're going to have nocturia often, and we don't want them urinating in excess. So you want them to hopefully be able to get a good night's sleep without having to get up and go to the restroom all night. They should also avoid spicy foods, caffeine, artificial sweeteners, alcohol as well, because those all irritate the urinary tract by increasing bladder distension. And fluid intake up to 2 to 3 liters, or 2,000 to 3,000 mLs per day, and restrict at night. So you want to continue to have the patient drink fluids unless there's some contraindication by another medical condition. You want them to continue to flush the system out. So that's why we encourage 2 to 3 liters of fluid. You also want to tell them, don't hold your urine, don't suppress it. Go to the restroom if you feel like you need to go. Go when the urgency begins. Take your medications as prescribed to relieve the obstruction and increase urine flow. Timed void schedules or voiding schedules. This is helpful. And what this means is that basically there's a time that the patient is scheduled to go to the restroom. So that could be, every 1 hour, it could be every 2, or every 3 hours, whatever the case may be. Usually not every 1, but every 2, every 3, every 4 hours. Then the patient should be encouraged to go to the restroom at that time. And that's just going to have the patient on a schedule, and almost like a bladder training schedule. And hopefully, they can urinate on a pretty consistent basis. Also, avoid over-the-counter drugs that promote urinary retention, such as anticholinergics, antihistamines, and also decongestants. So we have to be careful with that as well. Okay, well, thank you for hanging out with me as we discuss BPH, and I will see you guys in the next lecture, UTI.